Okay, people, I am going to start recording for this endocrine review. I am showing no camera. Why? Because I look like gaga. Yeah, 4 days at home now, being quarantined. My test did come back positive, if you haven't heard the good news. So next Monday and next Tuesday, the lectures will be on Big Blue Button as well. It's kind of a, I don't know, lackluster into the semester. I just kind of sucks. Really did have a good little party planned. That's the way it goes. Anyway, so we're going to do this review right now, and then on Monday you'll have the test on at 9:45. On Monday we have a short guest speaker from South Davis Hospital who's going to come and try and recruit you all to come work there. And then Tuesday we will, and we'll have a short lecture. It's only 2 hours on Monday, and then we have a short lecture on Tuesday for 2 hours. And then, people, hold on to your pantyhose. We're done. We're done. We're done. We're done. So hang in there, hang in there, hang in there. Okay, so let's talk about this diabetes here. Got a lot to cover, so let's get going on that. First of all, you want to remember the different types of diabetes. There's type 1 and type 2, of course. Gestational, pre-diabetes, secondary diabetes. There's certain drugs that can cause transient diabetes. So just put it out there, know what each one of them are, know how to differentiate from each one of them from another. Okay, I've got to find which cursor. I have two computers going here, and I've got to make sure that we figure it out. Okay, so we talked about the clinical manifestations of type 1 diabetes, and of course you have the classic 3 Ps, know what they are. Know what the clinical manifestations for type 2 are. Don't forget with gestational diabetes that it usually is transient and leaves after the birth of the child. However, the mother is more likely to develop type 2 diabetes later in life. Let's see what else we've got. Okay, we need to know what the normal diagnosis for diabetes is. So you know that it's 60 to 100, but when you have been fasting for 8 hours, what defines diabetes? It's anything with a glucose level greater than or equal to 126 milligrams per deciliter. And then don't forget the fasting glucose plus non-fasting glucose. And that's what I think I made mention of this earlier. This would be slide number 10. There should have been non-fasting glucose on there, symptoms of diabetes plus non-fasting plasma glucose. So instead of getting a finger stick, they're going to do a blood draw on you. You're not fasting, it's random. And so you just go in. But if you have not been fasting, then you're diagnosed with diabetes if it's greater than 200 milligrams per deciliter. Also, if you're given a glucose test, an oral glucose test where you drink that fabulous milkshake, then it can be 200 milligrams a deciliter. And then your A1C, if it's greater than 6.5%, you are diagnosed with diabetes. Okay, so we talked about pre-diabetes. This is where they don't treat diabetes yet. You just are on the cusp, you're on the verge. And they encourage you to start walking, to exercise, to change your nutritional dietary intake because you still have a chance to reverse that. Before you actually become diabetic, you, in that pre-diabetes diabetes stage, you have an opportunity to modify your lifestyle and change the results. You can, in fact, go the other way and not develop diabetes. So again, know what pre-diabetes is. It's considered anything between 100 and 125. With the oral glucose test, 140 to 199, and then your A1C of 5.5 to 6%. Okay, so we talked about 5 different areas of management here. We're looking at nutritional management, of course. We're looking at education. We're looking at monitoring. We're looking at pharmacological supplements such as insulin. And then we are going to talk about exercise as well. So there's 5 areas that you need to be studying for this exam and know the basic rules within each one of those areas. So the goal for nutritional management is preventing wide fluctuations in blood glucose. That's the goal for nutritional management. We also want to achieve optimal lipid levels, and we want to make sure that we have enough calories intake to maintain a reasonable weight. And if, you know, their person is a young adolescent, they still want to have enough calories to foster normal growth and development. So again, make sure that you understand what the goal for that is. Then the caloric requirements, again, they are going to give you a range. Anybody that has an ideal weight has a number of calories that you take per day to maintain that ideal weight. So what we're trying to do is calculate what the patient's caloric requirements are so that they can maintain an ideal weight. However, if a person is obese and they have type 2 diabetes, type 1 diabetes really with type 1, let me just start that sentence over. With type 1 diabetes, then we need to increase calories to accommodate growth and development. Remember, because these people are relatively young, they're under the age of 30, but with type 2 diabetes, then they may be develop type 2 diabetes because they're overweight, they're obese, and have a sedentary lifestyle. So for those type of people in type 2 diabetes, we're going to have, we're going to calculate what their caloric requirements would be for a healthy weight, but then we're going to subtract 500 to 1,000 calories so that they can have a weight loss of 1 to 2 pounds per week. And the reason why we want to do that is that a loss of 7% of the of a person's weight can decrease the need for medication and improve your blood glucose levels significantly to the point where you don't need that medication. So, and that's a weight loss of greater than 7%. So nutritional management has a lot of variables attached to it. Of the caloric amount that we need or that we take in every day, 45% of that should be from carbs, 15 to 20% of that should be from proteins, and 20 to 35% of that should be fats. Now, if you'll remember, regarding fiber, I said that with diabetics, usually the nutritional management includes that the person will have or consume the same amount of fiber as other people. I'm sorry, my voice is going. My voice is going. So I did talk to you about the different kinds of meal plans, the exchange, the meal. Just know that if there is one described to you that you can pretty much identify what it is, you don't need to know more than that. You need to know what constitutes high and low glycemic loads. And you do not need to know the foods that are involved for that. However, when we're talking about counting carbs, you need to recognize that 15 grams of a carbohydrate is usually equivalent to 1 unit of rapid acting insulin. So a person can calculate if they've gone out and had a few drinks, or if they've had gone out to eat that evening, or had a dessert or something like that, they can estimate the amount of carbs that they took in, and then give themselves some insulin to counteract those carbs. Okay, so one of the things that I wanted to ask you guys is, why do you think that we need to avoid wide fluctuations in glucose? And that, of course, I think I put that out there on the lecture, and somebody came back and said it's because the brain uses carbs for energy. It's the only thing that the brain uses, and the brain doesn't store carbohydrates. So you've got to have this continuous supply of carbs to fuel the brain. So that's why we don't want wide fluctuations. We just want a continuous flow of glucose to the brain. Let's see. Okay, dietary concerns. We're talking about alcohol here. So with alcohol, remember, we only want to use this in moderation. We're not saying don't use it. You can drink alcohol, it's okay, but only in moderation. Because if you remember, we talked about alcoholism or excessive amounts of alcohol can make a person hypoglycemic, because the liver will quit producing glycogen. And so once all the glucose in the body is used up, and the liver isn't producing any more glycogen, then you're going to be in trouble and become hypoglycemic. So you want to have at least 140 milligrams per deciliter of blood glucose before you go to sleep at night. So just be very aware of that. We talked about sweeteners. You don't need to know a lot about sweeteners. Just be leery that sugar-free and fat-free on food labels is not really true to form. Now we want to go into exercise. Now, exercise should be done daily at the same time every day. We want to check the blood glucose levels prior to exercise, and if it's too low, then we want to take a snack if needed. And if we are going to have long-term hardcore workouts that are greater than 2 hours, then we need to not only take our blood glucose before we begin, but every now and then while we're working out, so that we can take a little snack if needed. However, regarding exercise, you don't want hyperglycemia. So you don't want your blood sugar too high with the presence of ketones, because you're not very stable right now. So we want to wait until those levels go down and you stabilize a little bit. So here on slide number 26, we have some specifics for you. So I think that you would do well to look at that slide. And again, what are we trying to do is to prevent these wide fluctuations of glucose levels. Okay, as far as monitoring, remember that was one of our little circles of management that we're doing when a person is newly diagnosed. And first of all, they've got to be able to have the dexterity and the cognitive level to be able to not only perform the blood sugar stick, but they also need to be able to interpret the findings. So again, I think we talked a little bit about how ideal it was when a person was now able to self-monitor their glucose levels and recognize what's going on with their body, and it made all the difference in the world in how it was being treated. So one thing about the advances in glucose monitoring is that we can put on pumps, or we can have continuous monitoring now. We talked about on slide number 29 how there's a little catheter going in. That catheter has to be changed out every 3 days to prevent infection. But that catheter monitors the level of glucose in the blood, but it can also transmit that to a device to tell the patient to either consume more carbs or maybe add a dose of insulin. Ketones also, monitoring for ketones. It can be used with a urine dipstick that allows us to know if there are ketones in the urine. Usually we will see ketones in the urine when glucose levels get to be about 250 milligrams per deciliter, just so you know. Okay, like I said, we're not going to spend a lot of time on insulin therapy because you get that in pharm. However, just know that the oral anti-diabetic therapy is often prescribed for type 2 diabetics that aren't able to control their blood sugars with exercise and with diet modifications. All right, so the goal, what is the goal? Whenever we have a diabetic, then before their meal, we want their blood sugar to be between 80 and 130 milligrams. And then after a meal, and we're talking usually a couple hours after the meal, we want their blood sugar to be less than 180. And then we always want their A1C to be less than 7%. So make sure that you understand those figures. Also know the difference between Dawn phenomenon and Somogyi effect. And so let's look at some of the complications of hypoglycemia. First of all, we got to define hypoglycemia. Now, if the range is 60 to 100, hypoglycemia is anything less than 70. And extreme hypoglycemia can cause fatal complications. I think the lowest that I've ever taken on a resident before was 29, and he was not responsive. He was very lethargic, and it took a little bit to get his blood sugar back up. But we don't want it to get too low, below 70 at all. So there are going to be different signs and symptoms you see according to how bad the hypo or how low the hypoglycemia is. With mild, you're going to be sweating and tremors. Remember, this is somebody that's hungry, wanting to get out of class, out of lecture, to go get something to eat. I don't blame you. Happens every hour on the hour for me. So, you know, I just attribute it to that hypoglycemic all the time. But it can also be moderate, where you get the confusion and the headache, but the severe is when you are going to become very lethargic to the point that you're non-responsive. There can be a loss of consciousness, and it has to be treated within the hospital. That's when they have to start giving you some dextrose there, and they've got to be able to monitor that. So here, slide number 37. Yeah, you want to look at that, baby, and learn that one, because those are the suggestions of what to do for somebody that is hypoglycemic. All right, and then back and forth and back and forth and back and forth. And if you go into the, and you know, the thing about it is you are checking those blood sugars every 15 minutes, even if you give some D50W in the hospital. You want to recheck within 15 minutes to see how the body is reacting to that, because you will adjust your care according to what the figures are. All right, the next thing that we're looking at is acute complications of hyperglycemia. This again is when there's insufficient insulin or maybe an overabundance of stress. So look at the signs and symptoms for that and know what the difference is between hypo and hyperglycemia, because people oftentimes get confused. And know too that with hyperglycemia, with type 1, and only type 1, are you going to get diabetic ketoacidosis. And the reason for that is because there is no insulin. The body is not producing enough insulin. So the body is, all the blood sugar that the body has is just still floating around in the bloodstream and not getting into the cells where it can be converted to ATP. So the body's screaming for energy, so it starts burning fat. And the byproduct of that is ketones in the blood, and the ketones are going to turn the blood acidic, which makes for ketone acidosis. You do not get ketoacidosis with type 2 diabetes. You only get it with type 1. Be aware of that, okay? So what are the 3 clinical manifestations of DKA? Hyperglycemia, of course, you're going to have these really high blood sugar levels. Dehydration and electrolyte loss. And acidosis. And so if we're talking about what are we going to do about that, we are going to address those issues. With the hyperglycemia, we are going to rehydrate them immediately. And notice how much fluid we're giving, quite a bit, a liter in the first couple of hours, 2 to 3 hours, and then we'll go down to a half liter for the next little while there. But we need to restore their electrolytes as well. So we'll monitor lab values, especially potassium, replace any electrolytes that are needed, and keep that close eye on that potassium. And then we're going to reverse acidosis with type 1. So we have a slow continuous insulin drip, and the insulin drip is going to help with the ketone acidosis. And we may add dextrose so that they do not drop too fast because they can herniate, brain herniation. Okay, so we don't have ketone acidosis with type 2 diabetes, but we have something else that is very similar called hyperosmolar hyperglycemic non-ketotic syndrome, HHNS. And this is where there's insulin floating around in the body, but the cells are very resistant to letting it come in with the glucose. So the problem is here is that, yes, we're not getting enough energy, but we do have insulin in the blood. And so insulin is going to help take some of the glucose into the cells. And so we're not going to have the burning of fat for ATP. There will be enough glucose there, although relatively small. So you're going to have the same problems that you have there. You're going to have a dehydration, severe dehydration. So we want to rehydrate, and we want to replace the electrolytes as well. So there can be some precipitating events. The person could be really, really sick with pneumonia, stroke, or stress. They may be taking too many diuretics that are having them become dehydrated. Or they may have gone through dialysis, which has really dehydrated them as well. So again, some of the glucose complications are going to be that you have really high blood sugars, and you're going to have high osmolarity as well. And for the clinical interventions that we do are going to be the same: rehydration and restoring electrolytes. Do we need to do insulin administration? Yes, but it is not as critical as it is with ketone acidosis because we don't have the acidosis that type 1 diabetics have. So with sick days, remember the rules for sick days. Remember that we want to monitor the blood glucose every 3 to 4 hours. Why? Because if you're sick, the body's under stress. If it's under stress, you're producing cortisol. Cortisol has sugar in it, so you're going to have elevations of blood sugar. So you want to report anything more than 250, and you want to take your blood sugars every 3 to 4 hours. Let's see what else we got here. Other complications of diabetes mellitus is going to be your macrovascular complications, which is going to be your coronary artery disease, your myocardial infarction, your stroke, and peripheral vascular disease that we talked about already. All of these we talked about were had atherosclerosis as a precursor. Microvascular complications are where you have the teeny tiny little blood vessels that are affected by the large glucose molecules. So you'll have diabetic retinopathy in the eyes and nephropathy in the kidneys that can cause kidney failure or a person to go blind. And then you have your diabetic
Hey, Vicki.
neuropathies as well. And as a result of that, you often start losing the distal portion of the
Vicki,
extremity.
can you hear me?
Okay,
Vicki?
before we move on, there's a couple of questions that I just also want to review really fast before we move on to the different kinds. First of all, I pose the question to you, how often do you change the insulin pump catheter? Yeah, it should be every 3 days. Why do we want to avoid wide fluctuations in glucose? Because the brain doesn't store it. It needs to have a continuous supply. We talked about the rules of exercise. Avoid with poor metabolic control. You want to do resistance exercises, which is the best. Inspect the feet after exercise. Use proper footwear. Avoid exercise when ketones are in the urine. And we need to have a minimum level of 100 milligrams per deciliter if we're going to start exercising, and we may need to have a snack. Make sure you have a little snack available. And if you're a hardcore, 2-hour junkie, then you need to check your blood sugar more than once. Why do we need more than one injection of insulin daily? Because we're taking food in all the time. We're eating all day. One injection doesn't counteract the food intake well enough. How high does the blood sugar have to be before you can suspect that there's ketones in the urine? Uh, 240 milligrams per deciliter. So what is the purpose of self-monitoring? To achieve metabolic control. This should be self-explanatory to you. It should be logical, make total sense to you. You achieve metabolic control. You don't want to prevent episodes of hyper or hypoglycemia. Let's see. I don't think we talked about the risk factors for developing diabetes. You need to know those. People in their mid-40s. I did put a little disclaimer in there that children under the age of 10 are developing type 2 diabetes in the United States because of their sedentary lifestyles. And I'm not sure it's improved much with COVID. But there's a high genetic component to it. Also, African Americans have a high propensity to developing it. What type of diabetes has an absolute insulin deficiency? Type 1. That's right. What is a primary function of insulin? It stimulates transport of insulin into the muscle and adipose tissue. So what is the benefit of being at an ideal weight? There's no need for medications with type 2. It's true. So now, I don't know if I said this. Oh, I don't know. Let's see. Well, How do you avoid tissue atrophy with insulin injections? Did we talk about that? Rotating the site. You all know you have to rotate the site because of just your medication administration, sub-Q administration skill. But you can cause the tissue to start to atrophy if you keep injecting in the same place. The patient will develop these little nodules. How much fiber in the diet? You want to eat the same as the normal population. What is the recommended weight loss for newly diagnosed diabetes? 7% of their body weight. One thing we haven't talked about with this review is Kussmaul respirations. So go back to your respiratory lecture and see what Kussmaul respirations are associated with. Let me see what else can here.
Vicki, can you hear me? Vicki?
Okay, when electrolytes are being monitored during DKA, which electrolyte is being monitored? It's potassium. I think we've already talked about that. And the values will be very, very low because when, let me read my question. I'm trying to look at two things at once. With electrolyte monitoring, what is electrolyte that is being monitored is DKA. Okay, we talked about hypothyroidism. Oh, that's another one all the way. So I think I got everything covered that I wanted to cover for that. Let's go to these last little endocrine problems, and we'll just wipe that right out, won't we? I got to bring my PowerPoint back up on my multiple screens here. I'm just so high tech, you just wouldn't even believe it. Okay, so we talked about hypothyroidism and we talked about hyperthyroidism. So what is the cause of hypothyroidism? Oftentimes, what is the most common cause in the United States? Hypothyroidism. Hashimoto's disease, exactly. But what else can cause hypothyroidism? Not enough iodine. Not enough iodine. So it can also be associated with not enough thyroid stimulating hormone from the pituitary gland. So what happens with Hashimoto's is thyroiditis. In other words, with Hashimoto's, like we said, it's an autoimmune. So the thyroid stimulating hormone is working on a negative feedback system, and all it notices is there's no thyroid in the blood. So it's issuing more and more thyroid stimulating hormone. The thyroid is trying to meet those demands put onto it by the thyroid stimulating hormone, but it's not producing. But it's working harder. So what happens? You end up developing a goiter. Yeah. So the thyroid tries to produce the T3, but it just doesn't happen. You end up developing a goiter. All right, let me see what else I got going on here. Talked about that. We talked about that. Okay, so, and I hope that this would be pretty self-explanatory to you. With hypothyroidism, everything's going to be low, except your weight. You're going to increase in your weight. Weight is up, and fatigue is up, and your libido is down, but you just don't have energy for anything, and you can't lose weight. And then with your interventions, your person's not going to be able to tolerate cold, so you want to keep them warm. You want to monitor their weight. You want to monitor their vital signs and their glucose levels and their activity intolerance if they're just so tired all the time. They may be at risk for impaired skin integrity because they're not moving around as much. And of course, they're going to have imbalanced nutrition. Also recognize that myxedema coma is associated with hypothyroidism. All right, let's see. Thyroidism. Here we go. Hyperthyroidism. So this is the exact opposite. The most common cause for that within the United States is Graves' disease. It can also be caused by eating too much iodine. It can be caused by a patient taking too much Synthroid, which is T3 synthetic hormone. Just recognize what the cause of that can be. And of course, your clinical manifestations, everything's going to be elevated except for the weight. The weight will go down. And again, you're not going to have a great libido. Medications, don't worry about the medications because those are in the pharm class. With nursing interventions, we want to assess the airway, breathing, and circulation, check for bleeding and drainage. Again, this is if they've had a thyroidectomy. However, there's your signs and symptoms. Okay, one of the things that we need to stress is that you tell your people not to stop taking the medications abruptly. Make sure you take it at the same time every day and give them the signs and symptoms of a thyroid storm so they can monitor themselves. Okay, so the next thing that we're looking at is pheochromocytoma. And I screwed you up totally when I told you the wrong thing, but now I'm telling you the right thing. And it is a tumor that is found in the medulla of the adrenal gland. And so the thing that's happening here, remember, you're having an excess production of epinephrine and norepinephrine. And so your hypertension is going to be off the roof. You are going to have exaggerated fight or flight symptoms. So you're going to have you're going to have palpitations, tachycardia, tremors, diaphoresis. It's just like you're just a gallon of adrenaline has been dumped in your blood. And so it's very uncomfortable because you're going to be very, very anxious. So again, to determine whether or not there's a tumor there, they're going to do a 24-hour urine test on you. They may do a CT or an MRI, and they may do a surgical removal. But remember, 3 weeks prior to the surgery, they'll have you start taking medications that will be an alpha adrenergic blocker. Okay. So you can read your interventions for that. So the next thing is Cushing's syndromes. How is Cushing's syndrome diagnosed? The amount of cortisol that is in the blood and urine. So we do serum and urine cortisol levels. And so with Cushing, this is a result of something wrong being with the cortex of the adrenal gland. And this is where we have an increase in aldosterone and in cortisol being released. So if you have increased levels of cortisol in the blood, what is your risk for? Put you at risk for infection because it's high sugar levels. What will the nurse education include related to the risk for infection? So what are you going to do? You're trying to do infection control measures. And I have to tell you people, this is where you start collecting your little boxes for the final. So if I said infection control measures, you need to be able to identify performing frequent hand washing as a nursing intervention. Do not share personal care items. Get an annual flu vaccine. Notify the HCP if an infection occurs. So, yeah, those are infection control measures. Those are interventions that a nurse does if you're trying to maintain or to control the spread of infection. So, again, and that's applicable to anything that's at risk for infection. So another thing that is found in the, this is when too much cortisol, Cushing's disease is when there's too much cortisol being released. But Addison's is when there's insufficient amount of cortisol and aldosterone being released. So the signs and symptoms of a patient with Addison's disease is hypovolemia. So there's no aldosterone there, so there's going to be a huge loss of sodium and water. Hypotension, there's no aldosterone there, so there's going to be a huge loss of sodium and water, which means that there's going to be less plasma in the blood. So there's going to be hypovolemia. Hypovolemia is another word for hypotension and another word for dehydration. So they're all the same thing. Hypovolemia, hypotension, dehydration, that's all what Addison's disease is. Okay. I don't think we talked about the pheochromocytoma. What is a pheochromocytoma? Yes, it's a tumor that we've already talked about that. What will the patient exhibit with a pheochromocytoma? Well, if you're dumping huge amounts of epinephrine and norepinephrine, we've already talked about that. Hypertension, palpitations, tremors, we've talked about all that. Okay, I think I'm done, people. I think 41 minutes worth of 8 hours of lecture. You got it here. I'm here for you. All right, I wish you best of luck
Vicki,
over the
can you hear me?
weekend. Put your head down, study hard, take a little bit at a time,
Vicki.
and you'll get through it.
Vicki.
All right, I will talk to you Monday morning. See you then.